Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week's summaries. If you'd like to see those summaries, they're up on our website, and those were written by Joshua Belfer, Megan Hilbert, Alex Clark, Shannon Marcus, and Clay Smith. Okay, let's talk about some articles. Okay, now the fourth article, titled Foreign Body Ingestions in Children and Adolescents, a position paper of the European Society of Pediatric Gastroenterology, Hepatology, and Nutrition. ESPGHAN is how I usually say that, an endoscopic special interest group, published in the Journal of Pediatric Gastroenterology and Nutrition. All right, this is not an uncommon presentation. Children particularly like to eat foreign bodies. And so this is an updated recommendation for these children, and it has a lot of great information in here. It can really tell you what's going to be urgent, emergent. Are you calling in your gastroenterologist to do a scope overnight, or can it wait to the morning, or can this patient just go home and you can kind of watchfully wait as it comes out the other end? This paper is chock full of great, useful information, and it's not even that long, so it's very accessible. If your patient comes in with a foreign body ingestion, you can look into it, determine what it is, where it is, and you should probably know what to do based on this paper. In most cases, if it fits in your mouth, it's probably going to be able to go the rest of the way without trouble. But there are still reasons for endoscopic removal. Common places for things to get stuck in the GI tract are the hypopharynx, the mid-esophagus, the lower esophageal sphincter, the pylorus, the duodenal C-loop, and the ileocecal valve. So it's going to get stuck. It's probably going to be at one of those narrowing points. And depending on where it gets stuck, the patient is going to have very different symptoms. For instance, if the thing is stuck in the hypopharynx, they're probably going to present with something like a cough, dysphagia, drooling, adenophagia, and just pain in general. Compared with something retained in the stomach because it can't get by the pylorus, most of these patients are going to be asymptomatic, but this might cause vomiting and discomfort. If you'd like to see where it is, then of course the CT scan is quite effective. But if you want to do x-rays, then 2 x-ray views are usually going to be the most helpful because you want to know where it is in both planes. So once you've got this patient and you've established that yes, indeed, they have eaten some kind of foreign body, then the decision on whether or not to take it out is based on the type of object. Is it blunt? Is it sharp? Is it a magnet? Is it a button battery? The anatomical location where it got stuck, we just talked about that. The symptoms and the severity of those symptoms, as well as the time of ingestion. For most blunt objects, they're going to pass. If it gets stuck in the esophagus, then it's best that you try to remove it within 24 hours, especially if symptomatic. However, most things that get as far as the stomach, well, if they're larger than 5 to 6 centimeters by 2.5 centimeters, then it's likely not to pass the pylorus and may require removal. Other things that may require removal are sharp or pointed objects. These are things that are often going to have to be pulled out. However, you have to consider in which orientation they are and whether or not it's going to be safe for you to remove it. If it does get to the stomach, then you can still consider conservative treatment for these patients. If it gets caught in the esophagus, then often that needs to be taken out. Any patient that has ingested 2 magnets or a magnet plus some kind of metal object, not at the same time, obviously, if they're already stuck together, less of a worry, well, this is always going to be an emergency. Adolescents that present with foreign body ingestions, these can be more complicated. And this paper even talks about that. They even reflect on this, and I really appreciate that. That really showed an attention to detail. Many adolescents that ingest foreign bodies will have done so due to self-harm. And so procedures can provide kind of motivation for these ingestions, unfortunately. And so removals should not be done for everybody, but appropriate removal is still an appropriate removal no matter your intentions in swallowing that foreign body. Because we certainly don't take out all foreign bodies. Removal of even a benign foreign body carries with it a 2 to 8% complication rate. Most of those complications are mostly just going to be minor mucosal abrasions, but still, weighing that against the very rare risk of complication if it's a benign foreign body, then conservative treatment is often what's going to be, most appropriate. And honestly, in most patients without emergent symptoms, a lot of the time this can wait till morning. Complications at 4 hours versus 12 hours seem to mostly be the same. Although I will give credit to patients that most patients with foreign body stuff in the esophagus, no matter how benign that foreign body is, they tend to be very miserable. Can you give them something in the meantime? Say glucagon, which is a classic. This is not currently recommended. Most recent evidence does not show it to be effective, so no glucagon. Esophageal button batteries, these need to be immediately removed under general anesthesia. These need to be taken out as quickly as possible. If the button battery gets to the stomach, then it's less clear exactly what to do. And it's going to be more of like a case-by-case basis. Get GI involved, obviously, and they'll help you make the decision as for what's going to be best for that patient. Often, button batteries, once they've reached the stomach, they will pass on their own without any problems. The other thing that often gets removed is sharp foreign bodies, because if they get impacted, then they may require surgery for removal. So even without symptoms, there's a relatively lower threshold for removing sharp foreign bodies. All right, for the most part, that's pretty much the summary. Honestly, this paper is readable enough that if your patient comes in on shift, you could pull up this paper and get useful advice as for exactly what you should do with them depending on the foreign body. In a spoonful, this was a review of foreign body ingestions in children. And remember that decisions are made based on the type of object, the anatomical location, the symptoms and their severity, as well as the timing of ingestion. And then the fifth and final article titled CT First Resuscitation for Severe Blunt Trauma, a Propensity Score Matched Cohort Study, out of the Journal of Trauma and Acute Care Surgery. Now, I've been watching recently the old TV show ER, the TV show that from the 90s that the Pit was unofficially based off of. It's a great show. The medicine is actually pretty good. They do a lot of CPR for trauma patients, but otherwise, the medicine is really quite good. Now, for trauma patients, workflow is often the hardest part. You want to find out what's wrong, where it's wrong, and then get that patient to definitive care as quickly as possible while supporting them, usually with transfusions, as much as you can until you can fix the actual problem. So in Japan, they actually have some protocols that allow for direct to OR patients. So do not stop at the emergency department, go directly to the operating room to have your patient actually fixed. And this is interesting. But they've even one-upped themselves, and they've made hybrid trauma pays where they can do everything all in the same place. No need to leave the room for your CT or angiography, and the room even converts into an operating room, so you can have surgery right there in the same room you came into. This is some pretty cool stuff. Now, if you have all of these capabilities in the same place, then interesting questions can be asked. Like, what if the emergency physician's hypothetical dream actually came true? That is that they literally get CT'd pretty much as they come through the door before anything else, even the primary survey. The patient gets a whole body CT scan. Unless they're super unstable, that's a different story. If they require immediate airway intervention, then they were exempt, at least in this cohort, because, well, come on, you can't wait for anything if the patient really needs an airway right now. Otherwise, before the primary survey, these patients would get a head-to-toe, scoutless scan, non-contrast, and it takes about a minute to do total. So you're only delaying things about a minute. And the question is, once you have this information, are you delaying things? Or are you actually speeding them up? Now, because things tend to be a little bit more obvious for penetrating trauma, this trial only looked at blunt trauma because it's less clear what's happening in those circumstances. So they had all these patients that came in and they get an immediate first step CT, and they compared them to patients from a larger Japanese registry. And then they wanted to look at a few things. Are they delaying things, and are they really helping these patients? Now, these patients who had the CT first management, they actually required less transfusions at 24 hours compared to matched controls. An adjusted mean difference of 0.84 units, which was significant, but less than a full unit is not a huge difference in terms of PRBCs. They certainly had a shorter time to CT scan. I mean, come on, 0.4 minutes, which is really impressive compared to 29 minutes in the typical, typical pathway group for trauma patients. 0.4 minutes, that's really impressive. And then, of course, they did more CT scans. I mean, they did it in 100% of the patients with CT first management, and only 89% of patients. I mean, granted, though, it's still 89% of patients who presented otherwise. What was nice to see is shorter time to intervention, 54 minutes instead of 134 minutes. So that's a pretty significant change. And to top it off, less interventions if you had a CT first. Laparotomies only happened in 6% versus 12%, and damage control surgeries only happened in 4% versus 9% in the control arm. Only pelvic angioembolization was more common in the CT first approach, 10% instead of 4%. Though it is certainly worth mentioning that there was no significant change in mortality, but the study wasn't really powered for that. They only had just under 250 patients in this CT first group. So I'll have to forgive them for no difference in mortality. Now, if you just focus down on the slightly sicker patients, those patients that presented with hypotension, then the reduction in transfusions was a much more, almost 4 units less for that group if they got a CT first, which is interesting. The limitations for this, of course, they apply for most studies that are based on retrospective registry data. And so there's going to be, confounding potentially abound. But this is still a very interesting approach that if you had this available to you, I've certainly never seen this anywhere. It's very interesting, and this might become the standard of trauma care in the future as things go forward. Who knows if we can actually make that happen? It sounds like you need a lot of resources to do that. In a spoonful, in this blunt trauma retrospective trial with registry patients as the comparator, a CT first strategy showed decreased times to CT scan, decreased times to interventions, and less transfusions. Now, normally here I do a recap of the 5 articles, but it was just feeling redundant. So I'm going to skip it and leave it out from now on. If you really liked it, send an email in and I'll add it back. If you are hearing this right now, then you are not a part of the member students. I missed 3 articles from this past week. What were they about? Well, we talked about the PERC-PEDS rule for ruling out pulmonary embolism in children. We talked about a nice algorithm as for what you should do with patients who you suspect of having lung injuries. And then, is the gold standard really the gold standard for MSSA bacteremia? Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.